very similar to presentation of Dr. Ilir Osmani. That is the reason why I will skip a lot of slides. I don't go in terminology, in diagnostic procedures. Duga. Ne kratka se.
Koja je prva ili druga? Macular hole ili short macular?
Macular hole. And this is a retrospective study. It is a 3-year study, and I will present, I know financial interest. I will skip introduction. It is definition of macular hole, that is hole in complete retina. I will not talk about epidemiology. We already heard everything about that. I will stop here. This is interesting for pathogenesis of macular hole. It is a problem of separation of posterior hyaloid from ILM. We have synhesis, liquefaction, synhesis, collapse of the vitreous gel, posterior vitreous detachment. Complete separation from ELM, it's good solution. But some vitreous tissue remains on the ILM, splitting of cortical vitreous and do vitreoschesis. In that case, if in lamellar partial thickness separation splitting in the posterior vitreous, cortex occurs, hyalocytes and cortical gel remain attend to the inner retina. Retinal pigment epithelium cells and hyalocytes undergo fibrous metaplasia and contribute to ERM formation together with glial cells migration that produce premacular membrane. If premacular membrane goes centrifugal outward contraction, produce macular hole. It go inward contraction, it centripetal, it produce pseudo hole or lamellar hole. It is very important because not every hole is surgery treatment. Examination is mentioned before by Ilir. It is same, complete ocular examination, especially detailed retinal examination and OCT. In OCT era, we have good toys in our hands. Just few words about differential diagnosis. Before we have OCT, we have a lot of patients with suspicions macular hole. No, not every defect in retina, especially it seems like cyst or everything what we can see with fundoscopy. It is no macular hole. That is very often come macular telangiectasia or retinoschisis or any cystic problems in diabetic retinopathy, edema or Irving-Gass syndrome as a suspicious macular hole. What is very important, according to the International Vitrectomy Vitreomacular Traction Study, make good differentiation between lamellar hole, full thickness hole, and pseudo hole. You can see characteristic of the lamellar hole and pseudo holes. I will not read slides, but it is strictly described. What is important? That is important, no need surgery for lamellar macular hole. Lamellar macular hole, typically pseudo holes or pseudo holes with cleaved edges, are often stable of several years. It is advisable to distinguish the degenerative lamellar hole from tractional lamellar hole and pseudo hole because the benefit after surgical intervention is better for the tractional lamellar hole. The rationale for vitrectomy is the removal of tractional components of typically epiretinal membranes. It should be considered in cases with decreased visual acuity or OCT morphological progression. We follow that patient, and if we have that signs, we go in surgery. On right side, you could see two typical appearance of degenerative macular hole, mustache and top hat. This is interesting case. We published that last year. During corona pandemic, we have patient with complete macular hole. complete macular hole, and we advise surgery. But there was some vitreomacular traction and not complete separation of vitreous. But in pandemic, patient doesn't come, and after a year he comes with complete closure of macular hole and complete vitreoretinal detachment. This is not advised to wait 1 year to complete close, but it's happened. It's only one case. We published that, and it is interesting for things for this talk. Management, we see all management, of course, vitreoretinal surgery with complete removal vitreous, complete PVD, and then fill the eye with gas tamponade. Vitrectomy leads to closure of macular holes between 18 and 19% cases. We have sometimes failure. Why we have failure? It is not only me. Everybody has failure. Everybody who do this kind of surgery have to know failure is possible. It is a lot of investigation. It is a lot of articles on this theme. What is reasons for failure? We have two reasons, anatomical reasons for failure in macular hole. It is a hole larger than 800 microns, and this hole form factor is less than 0.5. It's calculated, and it is that anatomical reason for failure. Surgical reason for failure in macular hole is relief of tractions, persistence of an inner ring of ILM. During vitrectomy, we remove all the visible or the stained cortical vitreous collagen, but there is an invisible liquid component, hyaluronic acid, which is delivered from lacuna and collects to the posterior pole. It may be reason for failure. That is reason why after only peeling macular hole, peeling ELM membrane, I do drainage directly to the hole and completely close the hole on the table. Additional tools, inverted ILM flap, autologous flap, lens capsule flap, human amniotic membrane plug. And this is my short study to present anatomical and visual outcomes, surgical technique, 3 different modes of surgical technique I perform, depending on size of macular hole and disease duration, preoperative visual acuity, and earlier results of surgical repairs. There was 49 patients, 29 patients had pars plana vitrectomy only with ILM peeling, 18 ILM peeling with inverted flap, and 2 patients had pars plana vitrectomy with free graft of autologous neurosensory retina transplantation covering macular hole. How we decide what operate on which manner? The first was only ILM peeling in patient with macular hole less than 500 microns and duration less than 60 days. Inverted flap is bigger or longer. And the third technique was performed in patients where earlier surgical repair did not improve anatomical success in macular hole repair. Postoperative results were analyzed. Okay. Results. The first group of patients, we have complete anatomical and functional success, resulting in 0.4 measuring by Snellen chart improvement. In second group, we have in 17 patients anatomical success. In one patient had retinal detachment with inability to close the macular hole and decrease in visual acuity to hand motion. Both patients in third group showed anatomical success with closing the macular hole with very poor improvement on visual acuity. Okay, this is short videos with only macular ILM peeling and drainage subretinal fluid, intraretinal fluid in macula, and tamponade with SF6. That is patients from first group. On the right side, we have OCT before and after surgery. Second video is also short videos with temporal flap. We peel membrane first nasally, and on right side you can see OCT before and after surgery. Anatomical success is good. I always try to make flap just to cover the hole. This is maybe interesting for my first presentation. I here have a bigger flap, and I could, with Constellation, trim that flap. You can control vacuum and cutting even if you have ELM to cut. I cover by temporary by PFCL, remove with air and then with SF6. And last is one case. It was last eye in that patient. It was myopic patient. He referred to me with giant complete macular hole, and I preserve neurosensory retina flap, cover the macular hole, do retinectomy, complete laser, and an installation silicone oil after that. It was 3 years ago. He is still stable, and he is able to do life works, not especially. You could see it is a very large macular hole, more than 1.5 millimeters, and aspect after covering with neurosensory retina flap. As a conclusion, pars plana vitrectomy is a surgical approach, successful way of treating full thickness macular holes and improving anatomic reparation. Duration of symptoms holes have a crucially influence for functional success macular hole surgery. At last year, less complicated surgery. At last year, I haven't any, I have less temporal flap surgery covering and any neurosensory transplantation cases. It means that patients earlier comes to ophthalmologists, to retinal specialists. And my question for this panel, I hope we will be fast, even continued decrease in visual acuity, even thinning of the retina nerve layer and ischemic change on optic nerve head, despite the anatomical correct postoperative result, OCT, without any intraoperative complication. What is, maybe someone in panel have answer. I think process, functional process go worse even if we close the macular hole. Thank you very much.